Hello, my name is Dr. Nasir Shaban, and our topic of discussion today is obstetric emergencies. Welcome. Our learning outcomes is to recognize obstetric emergencies, to discuss steps involved in their management, to practice the skills needed to manage them, which will be done in the practical sessions. Let's start with prolapse. Well, cord prolapse is defined as when the cord slips ahead of the presenting part of the fetus and protrudes into the cervical canal or the vagina or beyond the vagina. The umbilical cord, we can diagnose cord prolapse when the umbilical cord is felt at the vagina following rupture of the membranes and is felt on vaginal examination to be coming down below the presenting part. As we know, cord presentation is only when the membranes are intact. So cord prolapse is when the membranes have already been ruptured. Cord prolapse should be suspected when there is an abnormal fetal heart rate pattern, especially if such changes commence soon after the membranes have been ruptured, either spontaneously or by artificial rupture of membranes. It is worth knowing the main reasons which leads to cord prolapse. A cord prolapse happens when the presenting part does not adequately fill the pelvis due to maternal or fetal characteristics. Sometimes it can be caused by disengagement of the presenting part during obstetric procedures, which can dislodge the presenting part. Or sometimes it's due to the high outflow of the amniotic fluid at rupture of membranes, which will lead to the cord being swept away by the gushing or the amniotic fluid which is coming out through the pelvic outlet. The risk factors which lead to cord prolapse are many, and we'll discuss few of them, which will include the breech presentation. Breech presentation is mainly because the pelvic outlet is not well filled by the presenting part. Now, the footling breech or the incomplete breech have higher incidence of cord prolapse compared to complete or frank breech. Transversely, because we have the lower part of the outlet, of the pelvic outlet is actually empty, so the cords are actually on the outlet, and any opening through artificial or spontaneous rupture of membrane, the cord will just slip out. A study which was done, one of the outer actually rated transversely to be number one in incidence of cord prolapse compared to breech. So number one was taken to be transversely, then followed by breech presentation, and lastly was the normal cephalic presentation. So we see a lot of cord prolapse in cephalic presentation because we have a lot of cephalic presentation anyway. Early or premature rupture of membrane can also lead to cord prolapse. Polyhydramnios, as I've said, that gushing of fluid will sweep away the cord in any polyhydramnios, given that the baby, the fetus is actually having a variable presentation, because given the big amount of liquor inside the uterus, so with that variable presentation and the sweeping away of the cord by the amniotic fluid when membranes have been ruptured. A second twin is associated with cord prolapse due to its small size most of the times, and at the same time because of its variable presentation. Now, how do we prevent cord prolapse? It's good to offer admissions to these women with unstable or transverse lies once they reach 37 weeks of gestation or more, and it's also important to offer admission to all women with premature preterm rupture of membranes and those with non-cephalic lies. What is the immediate care for cord prolapse? A cord presentation is an indication for immediate cesarean section. With cord prolapse, first thing is we shout for help, and when we're calling for help, we inform the theater team, the nurses, our seniors on the floor that we have a cord prolapse, and now the person who is managing will gently feel the cord to check if it is pulsating. If the cord is pulsating, then the fetus is alive. And then if this cord is outside the vagina, we should minimize handling it. We should minimize the drafts and winds to reduce the risk of vasospasm. So it's good to return this cord inside the vagina, and we can use a wet gauze just to push it back so that we avoid vasospasm and compressing it. Still on management, it's important to do an abdominal examination at the same time, and this should be done very quick, very fast, so that because every second counts in cord prolapse. So you determine the lie and the presenting part. As we've done the VE to determine the status of labor, the next step will depend on the stage of labor. It's important to know, is this patient of ours in first stage of labor or second stage of labor, and from then you'll know what's the way forward. Well, if the cord is pulsating and our patient is still in the first stage of labor, then we should try as much as possible to stop the presenting part from pressing the cord, and we immediately initiate maneuvers to resuscitate, we initiate maneuvers of intrauterine resuscitation, and every time we put these maneuvers in place, we monitor its impact on the baby. Now, there are many maneuvers which have been suggested which can help us decompress the cord from the presenting part. So we can do manual displacement of the presenting part by filling the bladder with around 500 to 750 mils of normal saline, where we put a catheter and we inflate 500 to 750 mils of normal saline towards the bladder. The bladder will contract. With contracting, it will push the head or the presenting part away from the outlet, leaving the cord uncompressed. It is also important to empty the bladder first before you inflate your 500 or 750 mils, because if there was a lot of urine already and you inflate this large amount of normal saline, you are going to cause discomfort to the mother. Clamp the catheter once you've already inflated your normal saline. Another maneuver which you can put in place is to elevate the presenting part using the knee-elbow position, which will show you shortly. If you're in a CMOC facility, if you're in a BMOC facility, and you want to, this woman is still in first stage of labor and she needs an emergency, as you've said, then do very early referral of this lady. Consider giving this woman tocolytics around 0.5 milligram of salbutamol IV slowly over 2 minutes, so that we relax the uterus and reduce the contractions. This picture shows how we're going to inflate normal saline into the bladder, where first of all we empty the bladder as shown in figure A, in figure A, and then once we've deflated the bladder, we inflate it with we infuse our normal saline until the bladder is full. That will push the head away, or the presenting part away from the outlet, thus releasing the compressed cord. This is the knee-elbow position, where the woman lies on her elbows and her face down while she's on her knees. With the use of gravity, the baby will tend to go down, releasing itself from compressing the cord on the bony pelvis. So this will actually help us in avoiding compression of that cord. We are in a scenario where the cord is still pulsating, meaning our baby is alive, and we're in the second stage of labor. Then we should remember that the safety of the mother is paramount. So in such a situation, we expedite delivery. We can use vacuum extraction or forceps, provided all the criteria are met. Remember, when using vacuum extraction, it's important to know the descent. So during the abdominal examination, just check if your descent is at 1/5 or below, to avoid yourself from doing hypelvic vacuum extraction, which can lead to a lot of complications. If the baby is in breech position, you can do a breech extraction, and this is easier for the second twin. It's important to prepare yourself for resuscitation because cord compressed. It doesn't matter how long it was compressed. Either it was compressed for fewer minutes or longer. In both situations, we really need to resuscitate this baby. So we prepare ourselves for resuscitation. We make sure that the resuscitation kit is with us, and we have enough manpower and skills to help us. In an unfortunate situation when the cord is not pulsating, then the fetus is always dead. It's also important to tell your friend or your colleague to come and confirm if the cord is not pulsating, so that you make that decision together. Deliver the baby by the safest method for the mother. Unless we have other obstetric indication for a cesarean section, generally we are going to deliver this woman by normal vaginal delivery. Obstetric indications which might lead to cesarean delivery even after the baby is dead may include 3 previous scar in cephalopelvic disproportion woman, or if the woman has labored for longer and we are risking a rupture or risking a VVF, or she has had a prior history of VVF, will help the mother by delivering this baby by cesarean section. We can now move on to twin delivery. And twin delivery, or what we call multiple pregnancy, we always diagnose through ultrasound during pregnancy, or sometimes we can do routine abdominal palpation antenatally, where we get the multiple fetal pulse, or sometimes we diagnose them after delivery of the first baby by abdominal palpation or by VE, where we note that there's still another baby. It happens. Now, let's talk about delivery of the first baby. It's important to prepare ourselves for PPH. So we'll follow the normal protocols during delivery, which includes inserting of an IV line, a large vocal cannula, to help us resuscitation in case of any eventualities. Have oxytocin infusion ready for after delivery. We'll then check for the presenting part, how it is presenting. If it is vertex presentation, allow labor to progress as for single vertex presentation. But if it is breech, we apply the guidelines for single breech. We know other countries allow the first breech or both breech twins to deliver vaginally, but in some countries they don't allow first breech to deliver. So check on the guidelines of your country if they allow to deliver breech with to deliver twins with the first one being breech. Beware if first twin is breech and the second is cephalic, because there is a risk of interlocking twins. So in such a situation where we've done an ultrasound and it has confirmed that the first one is breech and the second one is cephalic, we just do a cesarean section for this lady. Breech presentation can be vaginal delivery can be considered if your protocols in your country do allow. If first twin is transverse, then these are patients who will deliver via a cesarean section. Still on first baby delivery, Now, it's important that after delivery of the first baby, we leave a clamp on the maternal end of the cord. It's important also to note the number of clamps you put on every cord, because sometimes the first baby which was seen by ultrasound may not turn to be the first one to be delivered. And still, it's important, if it is cephalic, it's important to put one clamp on the first cord and two clamps on the second cord to differentiate between the first twin and the second twin, just in case you need to do a pathologic examination of the placenta. You know which twin had any issues, or in cases of twin to twin transfusion and other complications which might appear on the twins. So leave a clamp on the maternal end of the cord, and do not attempt to deliver the placenta when the first baby has been delivered. We can now try to delay the amstels, so we won't give oxytocin after the first baby delivered. This is to prevent the cervix from closing back and giving us difficulties in delivery of the second twin. When the second twin is coming, aim to deliver within 30 minutes after the first baby has been delivered. It's important to tell and explain to the mother and seek consent from her that this is another baby which is coming. Talk to her about the contractions. Talk to her about how this delivery is going to be conducted, especially if the second twin is a breech. You might need to do some maneuvers which might be uncomfortable to the mother. Check for fetal heart rate regularly after every contraction. Check your IV line is running, and then if there's a need for augmentation with oxytocin, it's okay to do so that you aim at least 3 or more contractions in every 10 minutes. Because you had issues with over distension of that uterus because of the multiple gestation, it's very important to prepare and anticipate for PPH. Still, with the second baby, we palpate the abdomen to determine the lie of the second baby. We can perform a vaginal examination to determine if the membranes are intact or they've ruptured, and if the cord has prolapsed or if the cord is presenting. It's also important to know the presentation of the second twin. Is it breech or cephalic? We can correct the longitudinal, correct the lie of the baby to longitudinal lie by using external cephalic version if it is possible and the membranes are intact. Or if not possible, we can try the internal podalic version by finding the fetal foot through intact membranes and conduct breech extraction. It is worth knowing that all these two procedures are done in a double setting, where the theater is ready and everyone is in the theater waiting for any eventualities which might happen, including an abruptio or a cord prolapse or any other complication which might arise from external cephalic version or the internal podalic version. And even sometimes the membranes might rupture during these procedures, and you might be forced to take another direction of delivery. Check fetal heart rate before and after doing these two versions. If we have a vertex presentation for the second baby, we anticipate spontaneous vaginal delivery. The second baby always comes out well because it's a small baby, and the first twin, if it's larger than the second twin, the space or the outlets has already been created well, so the second twin tends to come out fast. But it's not always the case. Sometimes the second baby is even slower and needs a lot of manipulation and maneuvers to deliver. Check for fetal heart immediately after every contraction. And then we can also augment for labor with oxytocin if necessary. We'll delay rupture of membranes until when the head is well engaged, so that we avoid those complications such as cord prolapse and other complications. If the second baby is breech, then we conduct breech vaginal delivery or a breech extraction. Fetal heart rate should be checked between every contraction, and it's also allowed to augment for labor if necessary. We also rupture membranes when the breech has descended, and we delay early rupture of membranes in the second twin. Other options to deliver the second baby is still as explained earlier, the internal podalic version in transverse lie with ruptured membranes, where we aim at the baby's feet and then pull them towards the outlet and deliver it as breech. It's very difficult to do, impossible if the baby is in transverse lie with the fetal back presenting. We can also do breech extraction of the fetal distress, or when we have cord prolapse or following an internal version. In most cases, a vaginal delivery will be possible. If not, we should consider a cesarean section for this mother. The third stage of labor, we ensure that there are no more babies before giving oxytocin boluses. Delayed cord clamping if the baby is not in need of resuscitation. Active management of third stage of labor, the normal way we always do the Amstel, which will include the oxytocin infusion. Up to that point, in case of any questions, kindly let me know. The recap of this lecture is: number one, we checked on obstetric emergencies and we knew that they are common and we should always be prepared. We should have clear guidelines which are displayed in our labor wards. We should practice regular skills drills so that we are in touch and we renew our skills to do different things like cord prolapse, twin delivery, so that everyone working in the labor ward is aware and is up to date on how these things are done. It's always good to call for help. No one is a hero in labor ward. Stay calm and focused. Always explain what is happening to the mother and your actions to the mother, and seek consent regularly. Thank you.